Hello and welcome to another edition of the Osteopathic Lyceum podcast. I want to talk about stuff that I've talked about before. So if you've consumed my content, you've heard me talk about the concept of assessment, so actual hands-on assessment in a variety of ways and why I say the things that I say. I want to go over that again in order to possibly provide another angle as to the foundations of why I say what I say. So if we consider the heuristics that I put forth for assessment, macro identifies micro is the first one, or large movements within the human body are made of smaller subcomponents, and when the large movement isn't working appropriately, you can usually visually see where the location of the restriction or the problem is. The next one is preferably patient active before patient passive. And patient active testing approaches, while not always ideal to identify full motion restrictions, you get a lot of good general information. So you get safety, which is provided to you by how far the patient is willing to move themselves. And that is the aggregation of a lot of factors. Some of those factors are going to include sensations internal to the patient that give them reason to alter their movement pattern or restrict the range of motion that they go to. Another safety cue that you get is whether or not the motion you request is initiated at all. If the motion you request is not initiated at all, you get some very, very superficial but not definitive cues that there may be a possible soft tissue tear or motor nerve issue or motor nerve damage, right? So the signal either isn't being sent or the movement can't be transmitted through the tissue. So there's no initiation of the movement requested at all. The large portion of patient active testing can be generally omitted based on the physical requirements to present in your office space or your treatment space, because the patient has to get from wherever they start to your office space. So there may be stairs, there may be elevators, there may be a curb, there's a distance between wherever they park, where your office is, there's doors, whether they be automatic or not. So if somebody has to pull on a door, you get some proxy that they can, not bilaterally, but at least some proxy. So you can omit a lot of patient active testing on account of the fact that the patient had to show up. So there's physical requirements to do so, which suggests that most motions and most tissues are probably safely intact or safely functioning. So you get some opportunity to omit a large amount of patient active testing, but it is still useful and it's preferable prior to patient passive. The rationale for allowing you to omit most of it based on the physical requirements to show up in your office space is because they have shown, or the preference is shown, that they can physically present themselves. You can understand what that means based on the general physical requirements to show up in your office. So there's some redundancy in how I explain that there, but for good reason. And then the final heuristic is be organized. So start somewhere, end somewhere. Now, in saying that, something that I should be exceptionally clear about is that you should ideally test paired structures in a paired way. So you don't want to test the right leg, then the right shoulder, then the left leg, then the left shoulder, based on memory requirements. So it becomes more obvious when you test the right leg and then the left leg, which leg is showing you a particular set of problems, then the right arm, then the left arm. Also, don't jump between, or be cautious that you go from one end of the body to the other, preferably in a paired manner, as opposed to something such as ankle, knee, hip, then shoulder, or then neck, then shoulders, as an example. Just be cautious with that. Again, you want it to consider workflow and memory flow. And realistically, you're always trying to manage cognitive load. You're trying to not make the assessment complicated by having too many tests or by trying to remember too many things. You just try to remember glaring problems. So macro identifies micro helps us do this quite well, because instead of testing every minor motion or every joint or every motion of a joint, the patient intake is going to tell you the things that you might want to add in from your standardized approach if you build a regular, consistent, standard approach. Because if you usually don't check small joints while the patient tells you about a small joint problem, you should check that. However, macro motions tell you in a really quick, easy manner which region you should zoom in on and further test to figure out what to treat, as opposed to every possible motion of the GH joint and the shoulder girdle. Just check them both very, very broadly in a very, very large predictable motion pattern. And whichever part of that predictable motion pattern isn't showing or is showing you a problem, you can zoom in on it. So be organized is aided at least to some degree, and reducing cognitive load is at least aided to some degree by macro identifies micro. So the reason that I advocate for a consistent, stable, standardized approach in your assessment that is guided by large movements, specifically large movements, so that you can zoom in as opposed to each individual joint and each individual movement, because your memory load, your cognitive load goes up, is because the consistency is the key, right? Now, you are definitely going to be omitting things. There's definitely going to be things that you are not doing, but you're doing that on purpose. So if we look into available research, this available research is not indicative of absolutely everything that is going on with the profession currently or even in the past, but it provides us at least a starting point to build an argument. Over time, so the initial research that I tend to draw from, and something that I should point to, is most people who engage in reading or consuming research are definitely going to have hallmark papers and what I would maybe term big hitters that they refer to a decent amount. It is incumbent upon them over time to try to see if anything updated has shown up or engage in attempts to update those hallmark or key papers. So the first one that I tend to look at is a paper from 1980 by Yuri Dinar et al. So it's DINNAR, brought in multiple osteopathic practitioners, brought in patients who were pre-screened for mechanical low back pain, and just observed what the practitioners did. One of the things that they observed is that the practitioners had an order that was internal to them, but their order for assessment was not consistent within themselves or between patients. So there was a low level of consistency. You translate that to general research that suggests that inter-rater reliability in osteopathy is poor, but something can be done about it. So generally speaking, very broadly, in your standardized, broad osteopathic environment, practitioners don't test the same as themselves or in a consistent order. And then that makes it harder for inter-rater reliability to be acceptable or good. And part of the rationale for that, or part of the thing that then jumps us to, is research done 2005, 2010, maybe a little bit after as well, by a group at ATSU or a group at AT Still University, Kirksville College of Osteopathic Medicine, whichever term you will get you there, or essentially the school in so the current name of the school, please excuse me for stumbling. The current name of the school is Andrew Taylor Still University, which houses several schools within it. So they have dentistry, they do have some sports medicine, they have some other hands-on approaches, and then they have the DO program, or the Doctor of Osteopathy program. That school is the American School of Osteopathy. So it is the original School of Osteopathy. It is altered name and altered some details, but it is the ASO in Kirksville, Missouri. They have another campus in Arizona. I just don't remember which city in Arizona. But anyways, all that to say, 2005, 2010-ish, there are papers from broadly Brian Dagenhart, Eric Snyder, and Karen Snyder. Amongst others, there are other contributors to the work. But what they were able to identify is that consensus training helps to improve inter-rater reliability. Consensus training means training multiple individuals to test the same things the same way. And you improve agreement between them because they're doing the same test the same way. So now we get a signal that stability of approach allows for more consistent findings, especially between people. So there's improved agreement. The things that improved the inter-rater reliability or inter-observer reliability most were pain provocation, essentially, so tenderness, as well as what I would call a yield to soft pressure. There's another term that they use that I don't have on the top of my head, but basically it's tissue texture change. That's the one. So tissue texture change, which is essentially going to be identified through yield to pressure. You're going to squish tissues, and the texture will be identifiable. So anywhere on my hand that I squish, so if I squish with my whole hand, I will be able to identify whatever point on my hand feels different than the other points, and then I can zoom in, I can move my hand to get better two-point discrimination. Either way, that group gives us some sense that if you test the same things the same way, that consistency of finding and agreement of finding can improve, at least with two criteria: pain provocation or tenderness and tissue texture change. So we have some fundamental concepts that help us. Also, when attempting to find something, a systematized approach, a systematized search approach is helpful. So we aggregate all this together and we say, use large motions to identify where smaller problems are so that you can zoom in on a region, not necessarily test every single thing. Preferably engage some patient active approaches to judge safety and also judge motor nerve function and soft tissue continuity, so possible or actual soft tissue tears, and be organized. So start somewhere, end somewhere, probably go from one end of the body to another, very, very generally speaking, not specifically or in an absolute way, but also you have to, in developing this approach, understand a large variety of ways to assess a large variety of things. Because if you don't, you won't know what is most advantageous to use and what is less advantageous to use. One of the ways to do this is you choose an area in the body and you purposely attempt to assess it active and passive in all positions. You will then identify whether active is more ideal, less ideal, or neutral when compared to passive testing. Because an active test and a passive test give you different information. There's an aggregation of information or an aggregation of factors that will limit patient active movement in a way that patient passive movement may not be limited. But patient passive movement may be limited by how the practitioner applies the passive movement. So they can be too rough, too abrupt, they can be too slow. So there is some skill required. But if you compare, say, cervical testing, so neck testing, patient active, seated, supine, lateral, and prone, you would then identify which of those positions gives you the best information. You would then compare that to patient passive and seated, supine, lateral, and prone. Now you have some legitimate insight into which of those are most ideal or which combination are most ideal. Superficially, what I will say is patient active seated cervical testing allows the most freedom of motion of the neck or the cervical region. There is the reality that the patient has the requirement to maintain an upright posture, so there's going to be tension involved in the neck, which is completely fine, but it's got the most freedom. Whereas patient seated passive, there is that requirement for the patient to keep their head upright, keep an upright posture. So they're going to have a harder time relaxing. You're going to have a harder time getting close to a variety of ranges of motions. Patient prone, depending on the table is going to get in the way. Lateral, the table gets in the way and the pillows get in the way. Whereas supine, the patient no longer has to maintain that upright posture. And if the practitioner is smooth, then they can appropriately identify ranges of motion ranges of motion that are problems, right? As a way to talk about how you figure this out. And then you have to choose an order. So you go through the full body like that, figure out what's most advantageous, what's least advantageous, and then you have to make some trade-off choices whereby I want to test as many things as fast as I can and as few movements as possible. Is prone good? So should I go seated, prone, supine, lateral? Should I go seated and prone only? Right? Should I go seated and supine only? Should I go supine to prone? Should I go lateral to lateral? What should I do? What gives me essentially the most effective approach to quickly figure out the areas that I actually need to zoom in on and pay more attention to? And also, I don't want to try to remember too many areas, because if I try to remember too many areas, my cognitive load goes up, right? So you're trying to manage your cognitive processes, your physical demands, the demands on the patient. You must always remember that the patient is the end user of all of your skill sets. The patient is the one that presents with an issue, with a challenge, with a complaint. You want to do your best to make it as comfortable for them as possible and effective for them as possible. So, as efficient as you can be, there's less load on them. As efficient as you can be, there's less load on you physically as well as mentally. The more complexity, the more tests that you utilize, the more points of failure there can be with cognition, especially, but also, and cognition being memory, so thinking, memory, interpretation, things like that. The more complicated you make any test, or the more complex meaning you ascribe to any test, the more points of failure there can be in your explanation. So if it's, say, seated active vertebral testing, don't try to figure out which vertebrae specifically is restricted. Just point to where it is and remember where that is, as opposed to saying it's this vertebrae on this vertebrae, because in all likelihood, you're wrong. Classic radiological versus palpatory studies will show you this. The variance in accuracy of locating spinous processes between practitioners and between individuals is quite high. So depending on things such as expertise and BMI, you will see as low as 26-ish, if I remember, percent accuracy of identifying SPs, and SPs, source spinous processes, are quite identifiable. So accurate identification of a specific SP is as low as 26% and about as high as 80-ish%, maybe a little bit lower depending on the individual expertise. And then the BMI of the patient. Now, BMI, some people like to complain about it and say that it's not an accurate measurement of particular things. It can't claim to be an accurate measurement of specific things because it's an aggregate measurement. It's two things. It's essentially distribution of, or a relationship between weight and height is a better way to put it. Now, that then relates to a bunch of other things that are surprisingly reasonable, but no, nobody would say that it's a measure of health. It's a nice measurement that can correlate and point in other directions of concern. So, how that said, generally speaking, the higher BMI somebody has, the more likely they are to have a higher amount of adipose tissue. So that adipose tissue then obscures smaller bony structures just because of fat deposition, subcutaneous fat deposition, and things of that nature, which makes it harder to be accurate with palpation. So if you attempt to be accurate and say specific bones, you're just more likely to be wrong. So if you remove that requirement, you identify the region of the motion restriction, you can at least remember the region, then you're going to be quite accurate. If you say it's a particular bone or particular bones interacting with one another, and you try to remember the neurology and say that means that this other thing is happening, it's more complex, you're making more assumptions, there's more points of failure. You're probably more wrong than you are right about everything you're thinking, but you're probably still correct about the region of restriction. So zoom back out, think about where it's not moving, and to whatever degree any other thing is related to the restriction you find, if you change that restriction, then whatever is properly related to it will change in some degree in relation to the amount of change. That then is a much fancier way of saying, find it, fix it, leave it alone. Nature will kindly take care of the rest, right? So be very, very cautious about how much meaning you ascribe to any test, because the more meaning you ascribe to it, the more you can and probably will be wrong. If you simply say, I did this movement test of this region and I found this portion of that movement to be restricted, you're probably accurate. Then what you do is you apply treatment and you retest with the exact same test. So this is another very important thing. Consensus training gives us the signal that if different people test the same thing the same way, they tend to agree more often on what they found. That gives us the impetus to say, if I tested it with the first way, I treated it with whatever way, if I retested a different way, then I have a harder time agreeing with myself. So I have a harder time being accurate. So if I test it with test A, I treat it with who cares what, and then I retest it with test B, there's a problem. If I test it with test A, I treat it how, who cares how, and I retest it with test A, then my ability to be confident in change improves. The ability to agree with myself that it did change improves. So these are fundamental things that really matter. If I tried to test speed with just a ruler to start, and then the second time the retest, I tested it with a stopwatch, I never tested speed, and I tested two different components of speed. So speed is essentially a relationship between time and distance, right? So it's how long did it take to travel this distance, and that will then be converted to speed. You use the distance, it's because it's the slash, it's like distance over time. Yeah, it's distance over time, and then that tells you how it goes. The problem with the how I started that analogy is essentially if you only use one half of the measurement, which is test A, to initially figure out what's going on, how far did it go, and then you use the other portion of the measurement second, how long did it take, then really you're testing different things and you're testing them at different times. So now you don't understand what happened. But if you use a ruler and a stopwatch to test speed the first time, you do something to whatever that thing that's moving is, and then you use a ruler and a stopwatch to test speed at the second point, and there is a change, you now can have confidence that there is a change, which is use test A to identify whatever the problem is, identify that problem, treat it who cares how, and then retest with test A, your confidence that it either did change or it did not change can be high because now you can agree with yourself. So internal consistency is exceptionally important. So again, as we've walked through and talked about some research, not necessarily an exhaustive amount of research, but some research that gives us meaningful signals that can then give us the impetus for how we organize our approaches, we can see that osteopathy often has a consistency problem with how it assesses things. Practitioners have a consistency problem with how they individually within themselves and between patients assess things. And we don't absolutely, as far as I can tell, broadly teach towards being consistent in testing approaches. We teach people a bunch of different test methods and say, do what you want. Now, that's not specific. That's very, very broad in general because there may be locations that do and educational programs that do teach test this way consistently or create a way to test consistently and then maintain that, acknowledge what you have omitted when your normal testing doesn't tell you what you want, pull on the test that you didn't do that might be appropriate for the particular context. I don't know that nobody does that. I don't know that everybody does that. Broadly speaking, in my observation, essentially very few do that. So we can, again, walk through some research. We can walk through some observational experience and say that everybody's going to benefit from a consistent approach to testing. And the heuristics that I put forth might help you build that. The suggestion of testing all regions, both in all positions and both or as well as patient active and passive, to compare and contrast and see what's the most useful is going to likely have a high amount of utility for you to then know which choices are most useful to make to be as efficient and effective as possible. So that's me walking through some of the research, some of the things that I've said before to try to bring out another angle or another set of phonemes, which are sounds with related meanings, to suggest to you why I say the things that I say and why I take the approach that I take. So hopefully, at least cognitively, that is useful to you. And please refer to, on my YouTube channel, the Osteopathic Lyceum, a lot of the assessment videos that I've placed there. So you can look at these and you can see what I'm talking about. You can get examples of these somewhat abstract concepts in a concrete way. So thank you for listening, and I hope you enjoyed.